I just wanted to give you a little bit of a background to and context to the second lecture that you have today, the lecture on what we call advanced care planning. The first point I want to make is that you'll see a lot of overlap between the the topic that Neeluji covered in her lecture just before the break and what we're going to talk about now afterwards, and that overlap is intentional, and you'll see that why that's intentional in due course. The second point I wanted to make is, and I will share my presentation now, make sure you can see it. Can you all see my presentation?
Yes.
Wonderful, thank you. So the point I want to make is that we're going to be talking about advanced care planning, and there are many different ways of discussing advanced care planning and advanced directives. Uh, there are dozens of presentations available out there. If you do a search, you'll find out what they are. The presentation that I'm going to go through today is one that's called Take Charge. And this is something that was developed by an organization in San Mateo. The concept of Take Charge was led by an organization in San Mateo called Mission Hospice. It's an independent hospice agency, and I happen to be a member of the team at Mission Hospice. I'm one of their community ambassadors. And one of the roles I played was in taking this concept of take charge that they had and develop it into a 4-hour workshop. So the workshop that we held would have a two-hour sessions 1 week apart, where in the first 2-hour session, we would talk about most of the elements of advanced care planning, introduce the concepts. Then people would have an hour, a week to think about things, think about their own plans. And then we would come back the following week after for another 2-hour session where we'd complete the session and then help actually people fill out their advanced directives and witness them so that they'd be ready to go. We won't be able to do all of that today in this one session. So I'm going to actually take this 4-hour package and give you the highlights of what we talk about in about an hour and a half. It doesn't mean you're going to miss anything critical. What you are missing is the interactive session in the workshop. We would have a lot of locations where we would have group discussions ongoing throughout the section. Since we don't have that ability to do it in this course, you're going to get all the content, but instead of the group discussion, I've sort of tailored the homework assignment for you so that you can think of some of the elements that were missing from the group discussion. You would replace it with the homework. Mission Hospice has allowed Sukham to utilize the workshop session that I developed for Mission Hospice, and have taught this workshop session for Mission Hospice in a variety of arenas, in for community groups, for groups of patients in Stanford Hospital, in the Stanford primary care setting, and so on. And they've agreed to let Sukham and me utilize this for Sukham's purposes, and I am in turn then bringing that to HCI to enable you to get this learning today. So I just wanted to acknowledge the support that we've gotten from Mission Hospice. We've got a number of materials from them that I have, and as I come to each of those materials, I'll let you know what they are. And they have been uploaded to Moodle. So each of you can download them from Moodle for your own use and utilize those as you do your homework and for your future reference too. Okay. So as I mentioned, Mission Hospice is, and actually Neeluji has a facility in Redwood City at Kaiser. The Kaiser facility actually, Neeluji can verify, uses Mission Hospice as one of their agents when they need to transfer patients into hospice care. So Mission Hospice provides hospice care to patients in Santa Clara and San Mateo counties in the Bay Area. And in addition to providing hospice care, as I said, they also do a lot of education and community outreach, which is where my role with them comes in. This philosophy that Mission adopts, and they're one of the few independent hospice agencies left in the Bay Area. This philosophy touches upon what the couple of messages I want to convey to you. The way we need to think about it, right? So we look at this. The first thing they say is that we believe that death is a human experience that touches every one of us, and that we each deserve care at the end of life that is aligned with our beliefs, wishes, and values. Right? And Mission utilizes that philosophy with, as Neeluji pointed out in her lecture, a holistic, team-oriented approach that takes care of not just comfort care, but physical, emotional, and spiritual care throughout that last phase of life. One of you questioned, well, what about the spiritual aspects of it? And as Neeluji pointed out, that's definitely also a part of the palliative care and hospice care that Mission Hospice provides. The other thing, I just want to go back to Neeluji's lecture and help you connect. We'll be talking about palliative and hospice care at stages through this presentation as well. And I'm going to approach it from the point of view of you and me as family members, and you and me as potentially as patients who have to deal with this at some point in their lives. Okay, so and as I said, Mission operates in the two San Mateo and Santa Clara Bay Area counties. For those of you who are here, they also have a hospice home in Redwood City with about 6 or 7 beds. So people who don't want to do hospice at home have the opportunity to, the option of going to one of their Redwood City location. But again, as Neeluji pointed out, hospice care can be provided in homes, hospitals, skilled nursing facilities, anywhere. Mission also provides what they call a transitions program, and palliative care is part of it. And for both for people who have lost loved ones, Mission provides bereavement support, grief counseling, group therapy support of various kinds. So it's a really a full service that goes beyond taking care of a patient in the last stages of his or her life.
And if I may add to the inpatient hospice home that they have, it's a beautiful service that they provide. But again, the important thing to keep in mind is that the service as a hospice is provided, but the board and care cost, which the bed that they provide has to be paid for out of the pocket. So again, even though you're in the inpatient setting and hospice is being provided, all the symptom management and the care provider would be free, but then the lodging and boarding has to be paid by the patient.
Exactly, and this goes back to the question that Narayanji asked in the last lecture, and the rate, the per day rate at for the boarding and lodging, so to speak, the hoteling costs is one way to describe it, runs about $350 to $400 a day.
That's right.
Something like that.
Yeah, it can get pretty expensive.
Yeah. So back to today's lecture, what I hope by the end of this hour and a half, hour and 3/4 is that you will recognize the importance of advanced care planning. 2, you will have the tools to do a few different things. One is for you to look inward yourself and explore your values and understand how your values might influence your end of life choices. And the second, which is also very critical, is having understood those values, start conversations with your family, those in your circle, and some people it could be friends as well as relatives, who you think need to know what those values are, so that they understand what your choices are going to be at the end of your life, right? Whether you make those decisions on your own cognizance, or whether you have someone else make them for you, you need to know, tell your all your family and friend circle who need to know what those values are. And that is something that we uh, typically don't understand or act on sufficiently, so that there's always there can sometimes be conflict with other people not understanding what you wanted when the time for making those tough decisions come, right? The third thing is you want to understand the role of what this document, an advance directive, and the other documents that I'll talk about that are used to record your healthcare wishes. We'll talk about what's called a healthcare agent. This is that person who will speak for you when you either are unable to or do not want to speak on your own behalf, to advocate on your for your own behalf in making important healthcare decisions for yourself. And then, having gone through all of these, you feel that you're ready, you have the right mindset to engage in these conversations, because a lot of as Neelaji pointed out, have superstitious and other blocks that get in the way of these discussions. For us, there's always more important things to do. Oh, this is not going to happen right now to us. We will put this off for another day, and sometimes that other day never comes. And we need to understand that earlier we understand this, earlier we decide, earlier we share these values, the better it is, right? We've talked about an advanced directive, and we've talked about an advanced care plan. Uh, think of a model of an iceberg, right? Most of that iceberg is underwater, and you see the tip of the iceberg on top. That tip of the iceberg is your advanced directive. It is that piece of paper on which you've put down your notes. But that you don't get to that tip until you have explored the whole iceberg, which is at the bottom. So we think of us looking at this iceberg and going from the bottom up to a point where we get to the top and look at the advanced directive. Okay. So with that, let me define for you what advanced care planning is. It's a process, and I've underlined process. It's a process by which you can take charge of the care you will receive when the time comes, by doing a few things: thinking about what matters most to you, recording those wishes in advance so that they can be used in the event that you cannot speak for yourself, and then communicating these wishes with all those who need to know, all the healthcare professionals, your doctors, your specialists, your hospital, right? As well as all your loved ones, especially the agent who's going to speak for you, but not only that person, but all the people around in the friend family circle who need to know about what your wishes are. And then we say, oh, this is only for the old, the healthy, the ones who are not healthy, or the ones who are unwell. No, it is for everybody. If you are an adult who's over the age of 18, you should be thinking about having an advanced directive in place. And we'll come back to how you would change it in time as you need to, but you'd build an advanced directive knowing what you know at that point in your life, and then you change it as you need to, which is why it's a process. You come back and revisit it, and I'll talk about that too. And you have to be proactive and do it sooner than do it later, right? It's for everybody.
So advanced care planning is similar to will, or this is a little different?
Advanced care will is, and that's a good question. We'll talk about that. A will is something that defines how you will leave your possessions to
Mhm.
other people when you pass away.
Yeah.
An advance directive is a document that talks only about the medical care, the care that you will receive when you're in a serious or critical situation where you are not able to tell the doctors, tell the medical team what you want to do for yourself.
Okay.
The document that we call a will is part of what we call an estate plan, which a lot
Mm-hmm.
of people think of, we know as a trust, living trust, for example, right?
Yeah.
And one of the documents in that estate plan is an advance directive.
Mm-hmm.
And most of us, we develop this plan, go to the lawyer, sign it, and then put it safely away in a safe deposit box where no one can find it. And that advance directive sits in the safe deposit box where no one can find it. And that is exactly the wrong thing to do with an advance directive. An advance
Mm-hmm.
directive we want to advertise to our healthcare professionals, to our family, to those who need to know. Okay, and
Mm-hmm.
that's a good question. I'll come back and talk about
And
that.
I think in a living will, you do have a section where you can say your wishes very briefly. But advanced directives explores, like Mukunji said, it's just a tip of the iceberg is advanced directive. But what's underneath it? Have you really explored your values, your goals, where you need to be, what you want to do? And it's the most important thing as a physician that I see. You may have done your advanced directive and stuck it away, and you may have named your son or your daughter or somebody, and they never knew that you have actually completed it
Mm-hmm.
or what your wishes are. And when something happens to you, and now we are bringing these people in because you named them and they had no idea, so then it becomes really, really difficult for the medical community to even begin to address what your values are, because now your values are in the hands of these two people who you thought will speak for you, but they don't know what you really wanted.
Mm. Okay.
Right.
Thank
And
you.
repetition, they say, is important in learning. And you'll find that some of these points that we're discussing now, we'll keep hammering up away at those points so that it kind of becomes uh, more important and rises more to the surface in terms of priority in your minds. Hopefully, it does that anyway. So let's talk about this entire package that we call advanced care planning. Why is it important? As Neeluji said, we all come with an expiration date. We're all going to die. We don't know what the date is. It's stamped on our back and we can't see what's written on our back, right? And most people, we have superstitions. We are queasy when we talk about death, our own death, especially, or death of our loved ones. And also, most people have feelings about how they want to go. None of us wants a protracted, how shall I put it, painful, long death, right? And we've the three quotes that I've given here are actually come from people that we've interviewed in these workshop sessions that I've told you that I give in the community here. And most common, we hear from people saying, I just want to go quickly. When the time comes, it's going to happen. Let it happen quickly. Right. The ideal death, many people have said, is you go to sleep one day and you never wake up. Right. Peaceful, calm, you're gone. Right. But then there's also some element of people that says, I am going to fight this like a boxer fighting to the 16th round, right? I'm going to go down fighting. I'm not going to give up. So there are different kinds of feelings and emotions people bring to the topic of their own death. They do this, but then they never share that with others, whether they have what the feelings are, what they want, what they don't want. And that is where advanced care planning comes. We talk about the importance of understanding why we want to do this, and then the importance of doing it in a systematic way, and then having the conversations with people. And we'll give you tips of how to do that, because very often it's difficult to have those conversations, both from our own internal hesitancy, we don't like to bring it up, and from the hesitancy of our family and loved ones who say, I don't want to talk about you dying, it's not going to happen yet. Let's go watch a movie today instead, something like that. So people have strong wishes, but they never tell others what those are, especially those that have a need to know. So here are some statistics that have been collected in California. 90% of the people that were talked to in this large survey said that talking to their loved ones about end-of-life care is important. Only 27% did this. This is a survey back from about 7 years ago, and the numbers haven't changed much. 60% of people say that it's extremely important that the family is not burdened by tough decisions about their care. I don't want my family member to make a decision that involves my life or death. I don't want to put them in that place of stress, that place of having to grapple with this thing, right? They all don't want to burden their people, but almost the same number, more than half, have not told their family members what they want. So there's a contradiction here. We don't want to worry them about it, but we're not willing to tell them what it is we want them to do when the time comes. So it's not just you and me and the next person that has the struggle. Uniformly through society, this is an issue. But in our community, in our South Asian and our Indian community, this is even more amplified than in the general statistic, right? So going further with this survey, in California, the same survey, they asked people about a variety of questions, and here are 3 of them. One of the survey questions said, the answers was making sure that I'm not a financial burden to my family was important, the top 5 for 2/3 of the people that were questioned, right? However, research suggests that 30% of the families lose most of their life savings when caring for a dying one. I think it was Narayanji who asked this question a couple of times in the previous talk. Financial care is something, finances related to end-of-life care is a huge issue, right?
Yeah.
People sell their houses to save their loved ones. And so this is a fact that exists, and we have to figure out ways of alleviating this the best way possible.
But even as a nation, we spend 80% of our Medicare dollars in the last month of life. So there's a huge discrepancy where we should be providing more care up front. A lot of our youth has diabetes and high blood pressure. We should be making stuff available to them so that they can live longer, versus what we're doing is we're spending a majority of our money at the end of life. Last month, we're not making a huge impact.
Right. 2/3 of the people that were surveyed said, when I die, I want to be comfortable and without pain. But the reality is that almost half the Americans who die without pain because they haven't effectively utilized the kind of services that Neeluji talked about in her last lecture, the palliative care service, and then towards end of life, the hospice service that provides comfort care and relief from pain, right? 70% of people would prefer to die at home. Interestingly enough, there are certain cultures where they do not want to die at home. The patients have said that if I'm near death, please take me outside my home, and I want to die in a hospital or somewhere else. And the reason could be as simple as there is some superstition if there's a death that occurs in a house, the people living in that house will be adversely affected in the future. There are all kinds of strange superstitions. While 70% prefer to die at home, same number die in institutions. Again, a mismatch. What we want, what we have as wishes for at the end of our life are not being realized. So this is a real human tragedy, a real human conflict that we need to correct. And the way we would correct is by having the conversation we're having now, by talking about the importance of advanced care planning, by making these realities known, and by teaching more and more people to advocate for doing the right thing, and by modeling that behavior by doing the right thing themselves, right? So what happens if you don't have an advance directive? Neelaji will talk about her training and the oath that she has taken as a physician, right? In the absence of any other information about your wishes, by the medical oath that they have taken and by the training that they've received all their lives, before they got into medicine, they are trained to pursue every single means necessary to prolong your life.
Yeah.
What that quality of life notwithstanding, right?
True. I mean, if you don't have the paperwork in place, if you did not say clearly and told your family, we will default to aggressive and full care no matter what the outcomes may be from that. So
And
it's
there
very
are moral and ethical and legal issues at stake here, but this is what they do. Right? So if this is not what you want, prolonging your life at all cost, right? If this is not what you want, you need to take charge. And even at some extent, you wanted your life prolonged, right? You would want to take charge to make sure things are done right. Yes, Rukiji, you had a question?
Question, comment. Actually, sometimes when used to tell people that, when they're in the last stages, I said, if you have an advanced directive, please keep it at bedside, because sometimes the caregivers panic and they call 911. And if the paramedics come in, they have to do everything they have to do. So,
Rukiji, that is something that we will be covering. So,
okay.
Yeah, this is going to develop slowly, but thank you for bringing that point up. And actually, when the paramedics come, it is not the advanced directive that they look at; it's another form, and we will talk about that. So please put that comment in, and if we have not addressed it, we will come back and talk about it. Thanks.
So I have one comment or question here,
Yes.
Mukunji.
Yes.
So we write our whatever the advanced care planning, right? And sometimes like, okay, we don't want to prolong our life. We just want to go, right? But the kids don't want to give up. So they want to try. Can they hide the advanced care planning and they can't do it?
So not if you have, and that's one of the things we'll talk about, to whom do you give? So it's not the advanced care plan that you write. You make the plan and you write it in a document called advanced directive. And the advanced directive is the legal document. And we'll describe those documents in a little bit of detail. But every hospital and most medical institutions now, especially for patients, older patients, they ask for the advanced directive to be loaded into the patient medical record. So they have it handy, right?
But I mean, I will add though, what Anita ji said has a lot of credence. That's why it's important to have those conversations with your kids and choose your agent who will actually follow your directives. Because if you don't, then they have the right to reverse what you had said. Even if you had written an advanced directives, now since they're your legal agents and you can't speak for yourself, they can reverse that. Okay. So it's important to have those conversations and make sure you have the right agent selected for yourself.
If you, for example, let's say take a husband and wife and they have 3 children and 4 other family members, and you pick one of that the husband picks one of those people to be the healthcare agent, the proxy. Not only should that agent know that he or she is the person who will speak, the others also need to be told that,
yes,
I have told this person to be in charge. And finally, you can consult as a group, but finally, whatever decision this person makes is the one that has to go. That information has to be conveyed. Right?
Okay.
So just to wrap this discussion again, this definition, I'm still at definition stage. It's a process. of taking charge of your the care you will receive by thinking about what matters to you, writing it down, and communicating that with everybody that needs to know. And it changes over time as your lifetime changes. So you should go back and repeat it, and we'll come back and discuss how to do that in some towards the end of the talk. And finally, what we need to understand is, and Lucy Kalanithi said this in about her husband, Paul Kalanithi, and we can talk about that later if you're interested in that story. Lucy Kalanithi says, this is a gift of love that you give to your family, the advance directive, because you're taking all the decision-making burden off their shoulders.
There's a lot of guilt that you are left with when you're making a decision for your loved one. So it comes with a huge responsibility. And if we have not told them what we want, it's a very hard decision to make.
Right. And also then there's the conflict that you talked about, different family members saying, no, you should try this, you should try that, etc., right? And sometimes issues, personal issues, animosities get into it. One sibling could accuse the other sibling of wanting to end a parent's life because that sibling wants to take over the property.
Yes.
All kinds of, and I'm sure you know stories like this too, all kinds of irrelevant things that have nothing to do with the quality of life of that person come into play. People optimize other things.
Yeah, it is very scary.
Yeah.
It's very scary as a physician to see that this person is suffering and somebody has secondary gain from that, and they're just hanging on to them because they will lose that in the process.
Right. So why is it that we as human beings avoid end-of-life conversations? First is, it's not going to happen to me. It's always the other person that's going to fall sick. We're going to be fine. And then the assumption that everybody knows. In fact, we've asked people in workshops where someone has said, oh, my spouse and kids already know what I want, and one of the children happened to be with that person. Do you really know what your dad wants? They said, no, he's never told me. Right? So they assume that everybody knows what they want, right? And as it is for a lot of us, the subject of death is uncomfortable to talk about. We don't want to address that. Let's push it off, right? You don't know exactly how you feel. You say, I don't know. I'll handle it when I come to it. I'll cross that bridge when I come to it, right? And invariably, it's too late to do that because then you're making decisions under severe stress, or maybe you're not even capable of making a decision because you're not conscious, right?
Yeah.
Or you feel, my doctor knows what to do. They're professionals, right? But they don't know what you want. Neeluji gave the example of her patient, Frank, right? Because of that conversation they had with Frank, she knew where he wanted to go to Hawaii. She knew he wanted to go for the graduation, right? So you have to have that information exchange with the medical team as well as with the family, right? Now, this booklet was developed by Mission Hospice. It's called Take Charge. It's a planning booklet that summarizes everything that I'm talking about in this lecture. I have uploaded this booklet with Mission's permission to the Moodle. You can download this booklet. It's a PDF document that you can keep and use for your own reference in the future. This is one of 4 or 5 documents I've uploaded. And Ushaji reminded me, when I come to a document, I'll talk to you about what's available to you. So here's a booklet that you can use as a reference. And it was developed not just by Mission Hospice, but by several other community organizations in the Bay Area that are listed here. And they're also listed on the back of the booklet. So I just wanted to give a shout out, a thank you and acknowledgement to all these organizations for making this really nice summary document available to us. Okay. So, as I mentioned, advanced care planning is a process. It could have 5 steps, 3 steps, depending whom you talk to. It's a multi-layer process. Take Charge is divided into 4 steps that I think are nice. The first step, as I mentioned, was you in turn thinking about yourself and figuring out what matters to you, then sharing all these wishes in fairly good detail with those who need to know, your family and friends, in making the choice amongst that circle as to who should be your spokesperson. And it's not always your spouse, it's not always your oldest child, right? And then once you figured everything out, writing it down and then sharing that document and not putting it away in a safe where no one knows where it is. We'll go through each of these steps, and you'll find out that write it down and share your plan is the tip of the iceberg, and the other 3 are where we spend most of our time. Because once we got the first 3 sorted out, the 4th is straightforward. It's pen on paper.
And more than thinking and acting on it and making sure that you have it documented, I think it's the communication that's important. Communication with your healthcare agent, communication with your family. And it's not, you can choose as many people as you want as your healthcare agent, but are they aligned? Are they thinking in the same way as you are? Oftentimes as physicians, we ask questions to families. What would your mom and dad would have said to us if he was sitting with us and knew what you know now about his health condition? So basically they're acting as a proxy. They're not taking over or taking charge of your plan. So that's the important communication that needs to go through.
Right. In fact, a couple of things regarding what Neeluji just said, and we'll repeat this later. The healthcare agent has different names. In the advanced directives, they typically call them healthcare agents. Doctors like Neeluji often call them surrogate decision makers. Neeluji used another term, health proxy. Some people talk about this as your legal language as your the decision power of attorney. Number of different phrases are used. They all mean the same thing. The person who is authorized to speak for you on your behalf when you are either unable to or don't want to speak for yourself.
And you can have primary agents and alternate agents, but surrogate actually is what is assigned by a physician or a healthcare provider if you did not have anybody assigned for you.
My question is about this healthcare agent. Do we need to assign in legal document particular person?
Yes, that, and I will come to that. That is one of the 2 main things in the advanced directive. Thanks, Kishorji. I'll talk about that. Right? Any other questions at this point?
Yeah, I just have I don't know whether to call it a question or a comment. I mean, there was a discussion about will versus advanced directive. I was just jotting down, my own version of it. Will essentially minimizes the pain and suffering to the survivors when they distribute your wealth after your time. And I look at advanced directive as a vehicle to minimize pain and suffering to self, right, when you're near the end of life. And it's also important to the survivors so that there is your will is worth the fight for them.
So Narayanji, the will is a document that talks about your assets, your possessions, and so on, other material things. The advanced directive talks mainly about your care.
No, that's exactly what I just said that will reduces the pain and suffering after your time when they divide your property. Advanced directive
very nicely put. Yes. That's very nicely said.
Yeah, and advanced directive reduces the pain and suffering when we are alive.
That's right.
And then when we are alive and nearing the end of life, and so that for the survivors, our will is worth the fight, because we may not leave anything behind if you prolong your life unnecessarily.
Yeah.
Maybe
that's what we need to add.
Good.
And it minimizes suffering not just for the person who is dying or the person who's ill, but for the family members around them too.
That's right.
So let's talk about step one. Here, what we're asking you to do is to sit back, contemplate, think for yourself, and consider what your spiritual and cultural religious beliefs are around care and end of life, what your wishes and values are for your own self, for your family, for your loved ones, for your community, and then what your choices are for medical care from the point of view of the term that Niluji used that we'll keep repeating, from the point of view of quality of life. Okay, that is what you need to think about, define, list, formalize. So that's what we'll talk about, how to go about step one. And in that connection, this is the second document that I've loaded onto the Moodle. This is a document called the Conversation Starter Kit. There's an excellent, and that link is given here as well, the URL, organization called the Conversation Project. That was started several years ago to deal with this issue of not being able to think about and communicating your wishes. And normally in a workshop session, we would spend some time talking about this document, but in this modified lecture format, I'm going to tell you what it is that we would have done, but this is something that we would encourage you on your own time to look at it. Review the document. It's about 10, 12 pages long, and they have some scales that you can look from easy to difficult, which define where for yourself you can figure out what steps are easy for you, what steps are difficult for you, what steps you need help with. Right? So this is a good way to understand yourself, to see where you are. Right? So this is a document that I've uploaded for you. And normally we would have a discussion about that after that. We're going to skip that discussion. But the point you will arrive at the end of this session exercise, if you should go through it, if you choose to do it on your own time, is that you will find that some questions you found were easy, but the questions you found for easy, some of your fellow scholars would find difficult, and vice versa. So the point is, this issue is highly personal. It's different from each of us. And then our background, our experience in life, where we are at the point in our lives, often will influence this decision making. And so these decisions could change for ourselves with time. And we have to understand that at this point in my life, I'm 30 years old. I have a certain set of things that influence me. That may change when I'm 50 or when I'm 70. So I have to come back and review things, right? And again, this is not a math question. It's not, this is right, that is wrong. There is no right or wrong. What only matters is what's important to you, right? And sometimes you is not you alone, but your immediate family, because we don't make decisions in isolation. We make decisions for ourselves and for our loved ones. And so that is something you take into account too.
Yeah, I mean, you could say I want everything possible, or you could say, you know what, I want this limited. I mean, I had a mentor who used to say, I'm not going to make my wife as my healthcare agent because she's going to pull the plug way too soon. So it really, so it depends on what you want.
Right. And the other thing is, you may find out that, yeah, I don't really care. Some people are like that. I don't care what happens to me, But it's important to tell your family that too, that whatever goes is okay, so hoga jo hoga, So each of us needs to, you and your partner and your sibling and your parent and your family member, your friend, each of us needs to figure out what the answer is for us. And it's different from each of us. I know a couple where one of them says, I don't want any life support. The other one says, I want everything done, so, and they've been together for 30 years, right? So it varies, right? Now, there are certain tools that help you with thinking about things. and help you with having a conversation. And if you're interested in exploring these tools, here is one that you might look at. It's called the Go Wish card game. It's like a game of cards. And it's developed by an alliance called the Coda Alliance. And this is a game that can be used to help people either think about what's important to them and also have a conversation with others. And if you look in this picture, there's a bunch of playing cards, and each card has a statement on it. It says, to have my family with me. Another card might say, to pray at the end of life. Third card might say, to have my dignity when I die. The fourth card might say, to have no pain, and so on. So you can use these cards to figure out through, let me show you, for example, you can use these cards to say, let's play a game that we pick and select 10 that seem most important to us. And from those 10, we pick 3 that from those we down select, or we can rank order from 1 to 10, right? And then we can have a conversation. I picked these 3 cards, you pick those 3 cards, right? Husband and wife. Tell me about it. Why? Why not? And that helps you start a conversation about things, right? So there are various ways of using these cards. So this is just one of the techniques available, which is quite popular, in fact, for initiating not only the thought process, but the conversation, right? And so the Go Wish, it says it can create a safe way to initiate conversations, alerts you to prioritize things, right? And give you some guidance on how to fill out your advance directive. And then begin to have those conversations with your family and friends. So when we think about our death, there's a whole list of things that we want to talk about: our financial arrangements, what we want to do with a certain precious object that has to go to my granddaughter, for instance, right? All the things that you put down in a will. And also, when I die, I want this kind of a cremation, or I don't want flowers, or I want this memorial service, I want this music to be done, I want my organs to be donated, whole host of things, right? Anything that's important to you. And these can all be adjuncts to an advance directive. But as far as advance directive is concerned, there are 2 main things and that's where we're going to focus the rest of this lecture about, that goes into your advanced care plan. And those 2 questions are, what decisions do you want about the medical treatment you either want or don't want at the end of life? First thing. And the second thing is, who is that person who is going to speak for you if your wishes regarding medical care need to be known, but you're unable to communicate them yourself to your medical team? So that's the healthcare agent. So how you want to be treated and who is going to talk for you. Those are the 2 primary components of any healthcare advance directive document. Everything else you can add on in sheets of paper, or you can put as part of another will or something else like that. But these 2 are critical elements that have to be there in every advance directive.
And for medical treatments, thinking about what should I want or not want could be a very, very difficult exercise. So the idea is not to go through every possible medical treatment that you may need, but I think it's important to think what the outcome you want. As a result of X medical treatment, am I going to be able to walk, talk, and be able to cognitively process and be able to have meaningful quality of life, however you define quality of life? For example, for me, being an independent person, I'm very clear that if I'm bedbound and if I'm cognitively not there, that is not a meaningful life for me. So then if you are making a decision for me to treat for my pneumonia when I'm having a compromised quality of life, I don't want that treatment. So that's how it gets related to it, because otherwise there could be umpteen number of medical treatments that you may be offered and you cannot go through the list and decide what I would want or not want.
So, and that's a perfect segue into the next part of this lecture. So, when you determine these choices of care, as Niluji was just pointing out, as part of this planning, you want to consider these options as you near end of life. And you can think of these options in these two categories, as she just pointed out. First, I want all measures to be taken to prolong my life as long as possible. That's an option you certainly can decide is one you want. Or as an alternative to that, you can have a second option that I want this measure to be done, okay, provided it fits my definition for my quality of life. And if this intervention, this measure does not do so, then I do not want it. So the second option is, do not take measures to extend my life purely to extend my life if they have no power to cure my illness and if it may restrict the quality of my life. Do not treat my pneumonia if at the end of it I'm going to be brain dead and in a uncomprehending state in bed for who knows how long, right? And this chart I will quickly go through, and then I'll ask Niluji to make some comments on. So this is where your understanding of your options comes. And none of us know in our particular case what specific interventions are going to be discussed. But every intervention, no matter what, can be dealt with in the way that this chart is going to describe to you. And in order to give you examples, we've picked here 4 or 5 of the most common interventions people are likely to have when they're brought into a hospital with a sudden medical need. And so we look at these, every single intervention from the point of view of what benefit it will bring versus what complication, what burden it will have. And we trade off one versus the other, and a risk analysis, if you will, and then make a decision based on that. And let me give you some examples of that. We have treatments such as CPR, resuscitation when the heart is stopped, when the breathing is stopped, feeding tube that Niluji described, ventilator breathing machine, which in this day of COVID, we all hear about a lot, right? Dialysis, frequently when there are complex things happening in the body, when the organs start to have distress, the kidney is the one that starts to suffer more and not. And then there's an option to do dialysis as an intervention, right? And then surgical interventions are pretty common. So here are a few examples of treatments that might be the ones that are being considered for a particular person. And for each of these treatments, there's a potential benefit. And what is that benefit? It could stabilize the patient if the patient is near death, it could postpone the patient, but it could potentially also bring the patient back to cure, right? Depending on where in the trajectory of illness the patient is. And then there are potential burdens, and those burdens are common to a lot of these, including discomfort, pain, isolation from friends and family, communication challenges, and then the need for professional support or hospitalization. If I need to be on a ventilator, I can't be at home. I have to be in the ICU, right? If I need dialysis, I need to go into a dialysis space or if I'm back and forth from home, or I need to be admitted for dialysis depending on my condition. So these are some of the things that you would at that point, if you are unable to talk, or your agent is talking for you, and you, or maybe you can talk for yourself, or your agent has to talk for you, you would ask the medical team, why is this being done? What benefit will bring it? Where will I be after this? Or you will ask, what is the downside of not doing it? Right? Neeluji, you want to take over and talk a little bit about?
Yeah, thank you. So, see, it's a few things that we need to really understand here is CPR is not offered to everyone. It is only offered when we have done everything possible medically. And despite our best efforts, now we're not able to sustain you. And this is a last ditch effort to make sure that we are able to pull you out of it. Unfortunately, CPR is not what we see in the TV serials that you do the perform the resuscitation and the next minute you're going out there and having dinner. I mean, the success rate is very, very low. Only 3% of the people survive this intervention, and out of that only 1% end up leaving the hospital. And whoever leaves the hospital has either cognitive disability, they're not able to function mentally, or they're physically not able to take care of themselves. So that's why when you get to that stage, it is very critical to think, is it the outcome that I'm looking at is what I really want? Because like I had discussed before, we have the ability technologically to put you on life support and sustain and prolong your death, but we don't have the ability to prolong a meaningful quality of life. So I think that's very important. Feeding tubes, at the end of life when your body is trying to shut down, the way body reacts is by not being hungry. I mean, just when we have flu, we are not hungry, we just lose our appetite. That's what happens at the end of life too. So when that's happening, when we are force feeding, which we can do two ways, one by a tube in our nose or a permanent tube in our stomach, your body is not able to process it. That's when we start to see that we have more symptoms, and the end of life looks much more miserable, especially in patients with dementia. So these are the scenarios where you need to ask that follow-up question and say, what are the end game of these interventions that you're looking at as a physician? And what do you think I will be able to do or not able to do if I chose these interventions as part of my care plan? So I think those are the follow-up questions that either your primary agent, your alternate agents, or you yourself need to ask and have a really thoughtful discussion ahead of time before, because when things happen, they happen so quickly. When we are coding people in the middle of the night, we don't even have time to phone call at some point. And if you don't have your directives, if you don't have your wishes documented, guess what? We are doing everything possible and we may not have time to call your family member. So even if you were thinking that that's not what I wanted, and if you had not put it down, it is not going to work. And dialysis, again, you're going 3 days a week for dialysis. It'll give you some meaningful quality of life if you don't have all the other things happening in your body too, because oftentimes when you get to dialysis, your body has already comorbid conditions. You may have heart failure, you may have diabetes, you may have high blood pressure, and things may be really going downhill. So the question is, what is going to take away from me? And what am I going to gain? Because 3 days out of the week, if you're spending your time in a dialysis unit and the rest of the time you're so tired and fatigued that you have no quality of life, then that's a discussion that needs to happen with your physicians. And same thing with surgeries. I mean, I had a 95-year-old person who came in with a blockage in her intestine. So the question was, is it worthwhile doing such a major surgery? And what is the end game that we're looking at? And hence the family decided it was not worth it. The patient would not have wanted it. So these are the questions that you have to think through and make sure that you're asking your physicians and your treatment team and get the answers that are in alignment with your goals and your wishes. So that's
your advance directive is not necessarily going to have a long list of 40 treatments like this, no. But what it's going to say is, if my treatment is going to have X consequence, I want it. If my treatment is going to have Y consequence, I don't want it.
That's right.
And that is all based around your definition of your quality of life.
Exactly.
So this is a clip which is about 2 minutes that if I can get to play, I'll have you listen to. Let's listen to it first and then I'll talk to you about it. Oh, I guess it's not playing because I tell you what, in the interest of time, I will give you a link and you can watch this clip on your own time, but I'll tell you what it's about. And you've seen something like this already, so this is not new for you. You remember the talk that Dr. Mahadevan gave you a couple of weeks ago on the what happens at the ICU at the end of life, in the emergency department in the ICU. This is a very an award-winning movie by a an intensive care doctor in the Oakland Hospital here in the Bay Area. Her name is Jessica Zitter. And she talks about decisions that have to be made at the end of life, which is it's a very powerful film. And this is just a trailer for that movie. It has about 90 seconds that gives you a flavor for what's happening in the ICU, the decisions that have to be made, and so on. You're not going to be losing anything by not watching it now, but if you have the time, certainly on your own time, you can watch it. Even if you Google the trailer for Extremis is the name of the movie on Netflix, you will find it and you can watch it. So the question we're saying is, again, I'm kind of trying to summarize this whole thing now. The central question regarding medical care in these end of life or serious conditions, situations is prolong my life as long as possible versus I do not want my life to be prolonged if there is little chance of a cure and or the burdens of treatment outweigh the benefits that I'm going to get from the treatment. That's kind of the construct that we recommend that you look at this in terms of what you decide is your quality of life, right? So the question is not do all you can versus do nothing. That's not the question. The question is, how important is my quality of life? And also for many of us, the question is, how important is our quality of life? Because we look at that not just as an individual, but as a family unit, husband and wife, a parent and child, that sort of family unit. So we look at it in that context, define the quality of life, and then everything else in terms of a medical decision in that benefit burden trade that we talked to you about, everything else follows from this definition that you have, right? And Neeluji spent an hour for you talking about this, so I'm not going to spend too much more time about it. This is where palliative care comes in. Palliative care can be an intervention, as she pointed out, that goes in conjunction with your curative treatment that you're having to address your quality of life. And when it's transitions to end of life, palliative care essentially morphs into hospice care, and hospice care is all the elements of palliative care, but without the accompanying curative treatment that you had the time during which you had palliative care, right? So palliative care, she's talked about what it does, that works in conjunction with ongoing medical treatment for cancer or heart disease or whatever else it is. And it's a consultative service, either available through the hospital you're in and community clinics, or one that you can have brought in if your insurance allows, in conjunction with what you're going on from another facility, right? And depending on, and it's worthwhile you're looking at an insurance policy to figure out how much it covers in terms of palliative care. And as Neelaji pointed out, hospice is covered by all Medicare and Medi-Cal programs. So hospice care, this is a good illustrative way to look at it, is a small subset of palliative care, which says, I'm going to do everything that palliative care does, the multidisciplinary teamwork, but without only when hospice is defined as last 6 months of life, potentially, right? And without the accompanying curative treatment, to keep a patient comfortable and in the environment that he or she wants at the end of life.
And I think one thing I would add also is that palliative care does talk to you and your family and elicit what's important to you. So any goals of care or value-based treatments, they will bring out these conversations and will continue to talk to you throughout your trajectory to elicit and tease out what's uniquely important to you as a person, as an individual, and then discuss it with your family members.
And that's right. And in fact, the palliative care team, I'm guessing Neeluji, on sometimes can even have discussions with the primary medical care team on what they've heard from the patient, the family.
That's right.
Yeah. And so hospice care, we've just defined what it is, right? And it's delivered wherever the patient is, and it's offered by many organizations such as Mission Hospice, who has offered us this presentation. And Medicare and most insurance policies cover it. And both these forms maximize quality over quantity and emphasize relief from symptoms, and is a holistic care that looks at psychosocial, spiritual, emotional, and existential support in addition to medical issues. So you, and this is again something we want to emphasize. Neelaji emphasized this from her physician point of view. You need to learn to advocate for yourself and your family. Doctors are not always going to come to you and give you the opportunity for this discussion, right? If you're faced with serious illness, seek answers that inform you, give you all the data you need to know, all the risk analysis, all the pros and cons before you make your decision. Learn about the prognosis and trajectory of your illness. What are the potential consequences of various treatments? What are the consequences of not having those treatments done? All in the context of quality of the life. How will it be affected either by accepting it or declining it? You have to consider pros and cons of each and then make a decision. But in order to do that, you have to be informed. In order to be informed, you have to ask questions. You have to advocate for yourself. You have to push. And sometimes,
if you're not getting answers from your own physicians, that's when you ask for palliative care, because palliative care goes through exactly the same sequence, will help you understand the trajectory of your illness. They will talk about the pros and cons or treatments and of the treatment modalities that you may need, the benefits versus burdens, and they will give you a clear idea. They'll coordinate care with the other specialists and give you a fair view of what lies ahead so that you can make the right decisions for yourself.
right. And then once you've got all that data, what do you do with it, right? So here's a thought process that we recommend you consider, right? You can ask yourself, or your healthcare agent asks on your behalf if you're not, right? How much am I willing to go through to have a shot at being alive? What kind of being alive is tolerable? What does being alive mean to you, right? Would you want to be alive but mentally or physically impaired? Neelaji said for herself, if I'm cognitively impaired, if I'm don't know where I am, what I'm doing, that's not being alive for me, right? Would you want to stay alive but not being able to care for yourself? You're cognitively there, but you have to have everything done for you, right? Is that being alive for you? Would you want to stay alive, but in the process have to be hooked up to equipment that keep you breathing or heart pumping? Do you want to be on a ventilator? Do you want to be on a mechanical heart machine, right? All of those things are kind of questions you have to ask about, right? And then there are different kinds of costs associated with each of these scenarios, right? It's not, cost is never just financial. It's a physical cost, an emotional cost, a financial cost, other costs, not just to me, but to my loved ones, to my family, right? Under what circumstances will I pursue a cure? When will I not, right? If my life is going to worsen, if realistically I'm going to have only 2 years left to live, or 6 months left, or 3 weeks left, right? Whatever that number might be, what is it that I want to do out of life, right? In those last 2 years, last 6 months, or last 3 weeks. Right? Those are the kind of questions you have to, that's the framework within which you have to make those benefit burden choices that we've talked about so far. So
there's a beautiful book by Atul Gawande. I don't know if you guys have heard of it, called Being Mortal. And he brings up these aspects beautifully and to elicit what's important to you. And it could be on either side of the spectrum. He brings up a beautiful story in there about a friend who made decisions for her dad and said, no, he would not want that surgery. He needed some spine surgery. And then she turns around and goes to him and says, what is the minimum quality of life that's acceptable to you? And he said, as long as I can watch TV and eat my ice cream, that's good enough for me. So she changed her mind, got him the surgery, and he was able to live a few more years. So this exercise is helpful on either side of the spectrum and helps you make the right choices in alignment with what your overall goals are.
Thanks, Neeluji. So, and this is again bringing up our cultural perspective. Choosing palliative care, or when the timing is relevant, choosing hospice care, is not giving up the fight. Society is going to say, you gave up, you let the person die. What's wrong with you, right? It's not giving up the fight. It's choosing to maximize the quality of life as long as you can. Is it worth that person being on a ventilator in an ICU for another 3 months just to say that person is alive for another 3 months?
Yeah.
Right? What is the cost of that to that person? Do we know how much pain and agony she was in? And what about the medical bills that mounted in the process, right? Money is not the important point here. I'm just saying there are multiple costs, and one has to look at it in that picture. But primary consideration is quality of life of that person. And if the quality of that life is important preserving, whatever cost we can manage, we should apply to preserve that quality of life. I'm not going to go through these next 3 charts in much detail, but the message and you'll have this to look at in later on. But the message here is primarily what Neeluji was conveying to you earlier. Now there are medical journal articles that have validated data that show that when patients have palliative care or hospice care, in long-term studies and short-term studies, patients live as long or longer with better reported quality of life with palliative care. Families are more likely to be satisfied with the care that the patient received and with the support they received with palliative care. And patients had fewer unmet needs for pain management or emotional or other support. So palliative care, now there's evidence that shows that, and that you saw the 2 graphs that Neeluji pointed out to. There's evidence that supports those graphs that this is indeed the case. And more, it's starting with oncology, but going into other medical specialties as well. there's an effort to integrate palliative care from the outset, from diagnosis into the curative treatment, whether it be oncological or heart disease or something else. And when they do that, again, they've reported improvement in symptoms, improvement in quality of life, patient satisfaction, and reduced burden, more importantly, for the person who's looking after that patient. It helps them a lot, right? So early involvement of palliative care also then makes the transition to hospice easy. Patients know all about it, family members know all about it, and futile intensive care, which again, Dr. Mahadevan talked to you about, and Jessica Zitter in that movie that I described to you also talks about, futile intensive care is avoided. And that's good for the patient, for the family, and for society, right? And so far, there's been no downside to early involvement of palliative care that anybody is able to figure out. So consider the questions that need answering. What do you need to understand? What concerns do you have about what lies ahead? And what trade-offs are you willing to make, right? That's what we've been telling you in the last 10 or 15, 20 minutes. How do you want to spend your time if your health worsens? When you start to understand your values and define things, this is the process that you'd follow. These are the questions you'd answer for yourself. And once you got that figured out in your mind, share it with your family, put it down in your advance directive, right? We've talked about this a couple of times, we bring it up again. You have to be the advocate for yourself. You have to be the advocate for your family member. Even if the doctor doesn't bring about, ask for palliative care services, ask about hospice services. Understanding these options will help a lot of anxiety. Neeluji can give you, spend 10 hours giving you stories about the anxiety that she has to deal with family members and patients. And it's not just about health, it's about everything else, right? And that helps them make the decisions to maximize quality of life.
And I think one of the barriers that I see, especially in our community, is that in India, care is very different than what we receive here. Here it's very individualistic, and it derives from what you want for yourself. Whereas in India, we've been just told, okay, well, you can do this, X, Y, and Z. So I think transplanting those values into a new society is sometimes very difficult, because here we will always ask you as physicians, what would you like? We will never tell you that this is what you should do. So then it becomes really, really confusing to make those choices. So hence it's important to empower yourself and have those set of questions that Mukundji talked about, so you can have all the information that you can get to make good decisions.
And this is one of the things we at Sukham do in advocating and educating the community. That's what Sukham does, is needing to understand these. You're living in a different cultural and different social environment. In India, we are reluctant to question a doctor. What the doctor says is law. Doctor said it, do it, right? In fact, doctors are trained to react adversely if they're questioned. Are you doubting my competence, right?
Yeah.
Here, that's different. Doctors are trained to be involved with the patients, answer their questions. In fact, even in some doctors, good doctors, encourage questions. Do you have any questions for me? Do you have any concerns for me, right? Do you need to repeat this? They will do the ask, tell, ask scenario, where they tell you what it is, ask you to feed it back, and make sure you understood it, right? So it's you have to learn to advocate for yourself, stand up for yourself. Right?
Yeah, very
not just here, in India as well.
Yeah,
Anyway.
India more so.
Yeah.
I mean, with my personal experience, they would not want to tell me what is happening. And if you question, then it becomes really inflammatory. And they will say things, well, do you think what's happening? And are you here? Well, of course, you're not there, but you still deserve to get answers to your questions. You cannot just be the law or the rule, and I can never question you.
Yeah. And Neeluji already talked about Atul Gawande. And, in that book that and some of you probably read this, there's this quote that we took out of this from one of his articles that he wrote. He says, usually people think about choices of care at the end of life as having a better death. And we're thinking about dying all the time when we're looking at this, at the scenarios. But what we don't completely forget, that it's not about dying, it's about living. How can you possibly live the best you can until the very end, in the face of all the impairments that grow with time, right?
Yeah.
So think of your advanced directive as not giving you, figuring out how to determine how you die, but think of your advanced directive and the advanced care planning as trying to help you and your family, trying to figure out how best you can live until you die. Someone has said that dying is the last act of living.
Yeah.
And until that last act is done, you're not dead, you're living. How do you figure out how best to live, right? What's the maximum you can get out of this one life you have on this earth, right? So remember, it's about life and it's not about death.
Yes.
That's the takeaway from this whole segment. All right. We've gone more than 50% of the way through the iceberg that's underwater. Now things go a little quicker, right? We needed to get that information to you because you really, really need to understand how to think about things, what questions to ask, what information you need. That's critical for you to understand that process, right? Once you've done that, now you're going to need to figure out who needs to know, right? So you want to talk about to your family, your friends, your doctor, right? And again, there's a link that I will give to you where ABC talks about the Conversation Project. This goes back to a news article, a news report about 7 or 8 years ago, I think, when Diane Sawyer was at ABC. Worthwhile watching. And it goes through one family where the parent is turning about 80 years old and their discussions about end of life at his 80th birthday. This is also worth watching. I'd recommend you do it.
And they actually even did a study on, there was a documentary on ABC as well. I think it was an ABC or NBC. They basically said they interviewed about a lot of people, so asking what their wishes would be at the end of life. And then they figured out that the physician group, when they interviewed them, they never wanted these aggressive interventions. So they were asked, like, how come you recommend this to your patients, but you don't want it? So the outcome, I mean, the answers were that we have seen it so close that it doesn't work every single time, that I don't want that for myself. So I think it's very revealing that how, even though we have advanced so much and we can offer the best technological intervention, but it is not very impactful when it comes to quality of life.
Mm-hmm. Correct, Neeluji. So, I'll start from the bottom of this list. Your healthcare agent, you're appointing this person, he or she, to speak for you. They definitely need to know what your wishes are, right? So your healthcare agent needs to know. Your doctors need to know. There's a question earlier, what if the healthcare agent overrides your instructions? And that comes down to the choice of the healthcare agent, how to choose one, which we'll talk about, right? Not necessarily an immediate family member, although most of the time it is. Your doctors and your hospitals need to know. And now, if you go to see Neeluji at Kaiser, first thing she'll ask you is your advanced directive in your medical care record. If you go to Stanford, they ask you the same thing. Anyone who's over 65 who goes for a wellness check and who's on Medicare, your primary care physician who does your wellness check is required by Medicare law to ask you if you have an advanced directive in the hospital system, right?
Yeah.
And lastly, your family and loved ones, they all need to know who your healthcare agent is, who you appointed, and what your wishes are. So these are the people, this is the subpopulation that needs to know about your wishes. And the conversation guide that I gave you gives you some tips of how to starting to have this discussion is very difficult sometimes. And page 8 on that orange booklet gives you a number of different starting lines or starting strategies. You remember how when Buaji died, this and this and this and happened, right? I don't want to have exactly that, but maybe, this thing that happened when in an intervention, I need that, right? So there are the various ways of approaching these topics, right? And you have some helpful hints in that booklet that I would recommend you take a look at. And then these are some of the points that you want to cover. What's most important to me? How would I like this phase? These are all the concerns about the health. These are the 5 or 6 personal things that I want to get in order, right? I don't want so-and-so to be involved in my care, right? I don't want this person to be involved in decisions. Make sure that this particular person does not participate. Make sure this particular person does. They're different. Every family is different, but these are the kind of things. Would you just let the doctor decide and let it be, right? So, and around this, and Neeluji's seen many instances of this. You probably know in your own friends and family circle, things like that. Disagreements and family tensions can tear families apart.
Yeah.
When I know of a story where a mother visiting from India fell asleep and fell sick and got admitted to the hospital and went to the ICU here, and she had come to visit the daughter. Daughter wanted to make certain decisions. The brother from India was accusing the daughter of doing decisions primarily for her own gain and not worrying about the mother. And it really tore the family apart. Now, if in that case there was an advance directive in place, both the siblings and the rest of the family knew what the mother wanted, and everybody knew who the agent was the mother had decided, that would have been eliminated, right?
And these are emotional times. There's no right or wrong. It really comes down to what each sibling thinks differently in realm of their own experiences and how life has shaped them. So they both, and then they start fighting. And this is a very common occurrence in the hospital. And we have to engage ethics committees. We have to really dig in to see who knows them the best. Because in California, there's a law that you don't really go by hierarchy as much as who knows you best. And that could be your friend who has actually lived with you, who not necessarily lived, known you for 30, 40 years and knows you like the back of their hand. So I think these conversations, not so much as even writing these documents, is the end product of these conversations, not necessarily what your thought process could be. And that's the important takeaway.
And the last bullet here, are there important milestones you'd like to be there if possible? Goes back to the example that Neeluji had with Henry, right? Or, I could say, I'd like to be kept alive and conscious for my granddaughter's graduation that's going to occur in 6 months or a year. If you can do that, that would make my life for me. Those are the kind of things you want to be able to share. So talking with your doctor, we've said, is important. Interesting thing is that 2/3 of the public believe it's important to talk to the doctor about the advanced care planning. But almost no one have. 1/10 of that have actually talked to their doctors in surveys, right? And more importantly, Neeluji can attest to this also, 9 out of 10 doctors are not comfortable with this discussion. They're human beings.
Yeah.
They don't want to be involved in these life or death kind of discussions with their patients. They'd rather treat them and move on to the next patient, right?
Yeah.
So it's important for you to take charge and do this for yourself. Be an advocate for yourself. This is another, there's a palliative care physician who got her fellowship at Stanford, is now a palliative care physician in the Southern California at USC. And she's published a very, very, very good book on end of life care. And this is an interview of hers on PBS, where she talks about palliative care and having the conversation with her parents and so on and so forth, which if you have time, you might want to listen to. All of these videos and things give you round up the kind of through examples and conversation, the notes, that the points that we're trying to make in this lecture. All right, now it comes, we're on step 3. We're approaching the surface. We're not yet there to see the tip of the iceberg, right? Choosing your healthcare agent. How do you pick the person who's best suited to this, right? So naming that healthcare agent or proxy, this is the person who will ensure that your wishes for medical care will be respected if you become unable to speak for yourself. You notice that it's not a person who says, who'll speak for yourself, but will help ensure that your wishes, they're going to stand up for you. They're going to make sure in the face of different conflicting stuff coming at them, different advice coming at them, they're going to ensure that your wishes are respected. So that person has to have that skill set and that strength, right? And this person has the legal authority, once you put the person as your healthcare agent on the directive, has the legal authority over others to make your decisions for you. It's not to say this person cannot consult with the rest of the family or the friend circle, but ultimately they're the one who speaks for you. Now, if you've not selected the agent, we've already discussed this, your friends and family may disagree about the medical care you receive. And then Neeluji talked about going to the ethics committee. There have been cases where they've had to suspend treatment while doctors and administrators and even the court gets involved. Judges have to be brought in to figure out what to do because there's disagreement between family members. You don't want that to happen under any circumstances for yourself or for anybody else, right? So it's important to have a healthcare agent in place. And what are the characteristics of this healthcare agent? They can talk to you about your wishes, know you and your values, right? They are concerned with your happiness and well-being, right? They're genuinely concerned about you. They're not afraid to ask the doctors questions and advocate for you. They're calm in a crisis, right? I had a patient who was helping fill out an advanced healthcare directive at Stanford Hospital about 3 years ago. And he said that he had all his 3 kids in his room, and he pointed to his middle son and he said, Mikey here, doesn't matter what it is, he is not going to talk for me. You know, I love him like to death, but he's not going to talk for me. It's going to be John here or my daughter here. John is my healthcare agent. She's the alternate, right? So understanding who can speak for you, who can be calm in a crisis, who can make difficult decisions even when it's emotional, who can make a decision that they disagree with themselves personally, but they know it is a decision you want, right? Who can talk to your family and loved ones in a compassionate, supportive way and explain things to them. And as I said just now, who will respect your wishes even if they're different from their own, right? These are the characteristics of an ideal agent. You may or may not get somebody with all of these, but this is what you want to look for when you make your decision. And again, after you do it, prepare the agent, talk to the agent, communicate with them all the wishes, right? And you can do various ways of communicating that are listed on this chart. But the bottom line, what this chart is trying to say is, it's not just enough to put it on paper, have a heart-to-heart conversation with the agent, go through all the quality of life scenarios that you can, and talk to them about potential conflicts, concerns, etc., etc. And then finally, now we've surfaced, we're treading water, and we're looking at the tip of the iceberg here, looking at your advanced healthcare directive. This is step 4, right? So now we'll define this document, right? We've talked about it for an hour and a half now. We're defining the advanced directive. And this is true in all states in some way, shape, or form. We're talking about California because we're in the Bay Area. In California, an advanced healthcare directive is a form that is used to appoint your healthcare agent and describe his or her authority to act on your behalf, right? And it guides the medical professionals and your healthcare agent to make decisions about your medical treatment in accordance to your wishes. Guides. It does not list 100% of all options. It's a general guide. Okay? So that conversation you have with your doctors and with your healthcare agent on the nuances are important. You can add as many pages with as much detail as you want to your advanced directive document. That's legal. However, you cannot anticipate everything. So you need to have some element of this person knows what I would want in every conceivable case. You want to have that kind of comfort in your mind when you authorize the healthcare agent. And if this person is not available for whatever reason, you can appoint a second and a third. California, I think they allow for up to 3 people, a primary and 2 secondaries, and the doctors will go through in sequence to see whom to contact until they find an agent to speak on your behalf, right? Just reminding you that if it's not there, if they can't find the document, if it's hidden in your safe and no one knows where it is, even if you had one, they may consult. Neeluji may go out and talk to the family to know if they knew what your wishes were. But in any kind of doubt, they would have to do all the measures required to prolong your life, right? And family, it's emotional. There's disagreements, there's stress. They don't know the full picture. They've just flown in from out of state, whatever it is, right? If you have done it ahead of time, you've given a gift to your family and to yourself. So think of this as the next Diwali gift, the next birthday gift to your family, right? An advanced directive. There are a number of different documents. I have uploaded the official California Advanced Healthcare Directive to the website. You can download and look at it, but that's by no means the only document. If you ask Neeluji, she'll tell you that Kaiser has its own Advanced Care Health Directive document. Stanford has its own. UCSF has its own. There's a document called 5 Wishes that is actually a very nicely written document that enables you to put down all your things in a way. There's a pictorial version of the California Advanced Healthcare Directive that's 14 pages long, that is developed by a group in San Francisco, where it guides you through in pictures to figure out what you want. Every different state has its own directives, and now more and more there are online versions. That's the picture on the right side of the screen here, where you can go online and answer a bunch of questions like you would do if you use TurboTax to fill in your tax return, and it'll spit out your advanced care directive at the other end, and it'll upload it to the cloud and send it to whoever you want to send it to. So there are different technology applications that are coming too. Bottom line is, even if you wrote it on a piece of paper and got it properly witnessed, it is a valid legal document in the state of California. But using one of these forms is the recommended way to go. Important things to remember is, as long as you're around to talk about it, you don't need this document. It only comes into play if you're unable to speak for yourself. And as I mentioned, any form is legal if it's appropriately signed. And in California, you have to sign in front of 2 witnesses who are not members of your family or not members of your medical care team, right? And if those people, they don't need to know what's in your directive, they just need to say, I have seen this person sign this document, and they witness it on the same document, saying, I saw this person sign, it's a legal document. You can also, if you want, go to get it notarized, pay $30 and get it notarized, but you don't need to if you get it witnessed properly, right? And as I said, all these forms vary in the detail about treatments and other care issues. Some of them bring in organ donations, etc., etc. Some of them says, here's a blank sheet, 1 page, add any detail you wish. Others will say, attach pages with this, initial each page, and that's part of your directive. You can add as much as you want. But for two fundamental things is naming your healthcare agent and broad guidelines as to what you want to do in terms of these critical medical procedures, right? Once you've done it, do not hide it in your safe. Discuss it with your healthcare agent. Give a copy to your agent. Discuss it with your physician and ask that it be entered into your medical system on database, into your electronic medical record, your EMR. Discuss it and share it with all the important family members so they understand X is your healthcare agent, Y and Z are your alternative healthcare agents. These are the things I want. These are the things I don't want. And you can have a discussion, but ultimately X is going to make the decision on my part. That releases the stress on everybody, right? Now, one other form, and this came up early on, I think Rukiji brought it up. There is one other form that's called a post. A post is different from an advance directive. It's hot pink for a certain reason, and I'll talk to you about in a minute. A post stands for physical or physician orders for life-sustaining treatment. This is not a document you work on your own. This is a document that you have to work on together with your physician. You have to discuss with the physician, and your physician has to sign this document. That is why it's called a physician's order. This is a document that you would have only if you have been diagnosed with a serious illness and your life expectancy is 2 years or less. That is one definition. There are other definitions of when you should do a post. But post is not an advance directive. It is a document that briefly describes in an emergency situation, right? What is it that is done by a medical team? It's hot pink because the 911 folks, the fire folks, the EMTs are trained to come in and look on your refrigerator. If they see this pink document, they'll pull it down. And it will say what to do in terms of a CPR, what to do in terms of medical intervention. Should you have only comfort measures? Are there any limited additional interventions? Do you want full treatment? So if they say attempt full CPR, they might do it in your home on your kitchen floor. Or it might say do not attempt. There's a DNR, which is what Neelaji was talking about. If the DNR is blocked, they will allow a natural death, right? So this happens in an emergency situation. 911 is called, or you're rushed to the ER. The post, if you carry it with you, and some people do actually have these envelopes, or if the post is also entered into the hospital's base, they know whether or not or how to treat you in an emergency situation. So this is a document that is an adjunct, a second document that can accompany an advance directive, does not replace an advance directive, and is a document that comes into play only when there's a limited lifespan, you've been diagnosed with a serious illness, and you should now be ready to tell people anything can happen anytime. This is what I want in an emergency situation.
Or patients 85 and above can have the pulse too, because at that age, you never know. One event can make things crash immediately, so they can have the pulse. And I think the first section is when you don't have a pulse and you're not breathing, which means that technically you've already passed away. In that situation, would you like them to still resuscitate or not is the question.
And in that case, as Neeluji pointed out, CPR, especially with an older patient, a fragile patient, the mechanical process of CPR is more likely to crush your rib cage and kill the person rather than try and resuscitate the person. Right?
That's right.
So there are different issues related to that. Okay, so now we have gone through everything that we have talked about. If you already have your advanced care directive, you may still want to review this whole process, and we recommend you review this whole process and see if there have any thoughts that you want to change or something like that. And I'll talk to you about changes in process in just a bit. We are not going to have a follow-on session in 2 weeks, in a 1 week for the 2-hour session as we would do in the workshop. However, if you would like to, there's a follow-on discussion that I will have with Usha ji this Saturday from 8:30 a.m. to 9:30 a.m. Pacific Standard Time, Pacific Daylight Time. So if you still have questions about advanced care directives, I would be happy to answer questions at that time. So you have between now and Saturday to look at this, think about it, right? The key takeaways we want to leave you with are the following. It's important for everyone, if you're over 18, if you don't have an advance directive, if a family member over 18 does not have an advance directive, talk about getting one, advocate for getting one, right? It's not a document that you write when you do your trust and file away for 30 years, right? It's a process that I've talked about. It's a planning process, it's a thinking process, and processes that take into account changes with time. And the goal is to create an ongoing engagement in critical conversations. Your personal values, think back to your life. Each of you is at least 30 years old, I presume. Think back in 10-year increments, right? Did your values and your world vision change? If you're 60 or above, look at the last few decades. Did your values and world vision change? Did your what's important to you for life change? These things happen. They've changed for me, I know. I know they've changed for Neeluji, right? They probably changed for you. When those changes occur, you have to ask, now, does that change anything in my directive? If so, you have to capture that change, right? So it's a process. It's a 4-step process that we've talked about. You think, you talk, you choose, and you write. And you repeat these steps regularly, especially after major events, to make sure that the latest version of your healthcare directive reflects your wishes. Now, if you had a directive you wrote 10 years ago, and you have a directive you wrote 6 months ago, you have a directive you wrote 2 days ago, what is important is the date on the directive. Whichever is the latest is the functional document, no matter how many directives exist, if you haven't torn them up, right? So the date on the directive is the important one. And in terms of when you would do this, the American Association of Estate Planning Executives has a recommendation that they call the 5 Ds, okay? The first D is death. When there's a death in your immediate family circle, look at your directive and say, does this change? For example, if your health agent died or one of the alternatives died, you have to change your document, right? If there's a divorce, then you may need to change your document. You may or may not, but you have to relook at document. If you receive a new diagnosis, that's 3rd D, right? You have to look at your healthcare document. If you suffer a significant decline in your health for whatever reason suddenly, not a disease, but a decline in health, look at your document. And then the last D is decade. Every 10 years or so, 10 years have gone by in your life. Have your worldview changed? Have your values changed? Look at your document. So the 5 Ds are death, divorce, diagnosis, decline, and decade, right? Those are kind of suggested milestones, but you may choose your own milestones. But important thing is revisit the planning process, revisit the directive, and if it needs make changes, make those changes. Ellen Goodman is the founder of the Conversation Project, which created that yellow booklet I told you about that I've uploaded for you. This is a great statement she makes about advanced care planning. She says, most people have this position. It's always too soon, and then one day it's too late. So don't push it off. Don't procrastinate. Do it.